This conference will now be recorded.
All right, I'll get started. Navin, that's okay? Or should I wait a little bit?
Nope, go ahead.
Okay, sounds good. So, hey guys, today we'll be talking about an article that investigates this question: is out of hospital use of ketamine safe? So, one second. So the article was published in the Annals of Emergency Medicine just recently in July 2021. It was done by Fernandez et al. Um, So why investigate this question? Basically, ketamine is increasingly popular, becoming increasingly popular both in EMS and in the hospital for multiple different uses. It has potent effects. There's a wide therapeutic window, and there is reportedly a favorable risk profile. It's used in multiple different clinical for multiple different clinical reasons. It's used for analgesia, sedation, seizures, etc. However, it doesn't come without complications or side effects. Some of those include respiratory depression, excessive airway secretions, emergency reactions, and the catecholamine surge that results in hypertension tachycardia. And if you give it in large doses really quickly, it could result in laryngospasms. Recently, there have been debates about the safety of ketamine and alternatives that can be used instead of it. And so that's why this study is aimed to determine whether ketamine could be reasonably excluded as a contributing factor to patient death. Specifically, the title of the article was, out of hospital ketamine indications for use, patient outcomes, and associated mortality. So the focus will be on mortality, but as we'll get to later, um, in order to get to that primary outcome, they did investigate other side effects or complications that could result as by administering ketamine. Um, so going down the PICO format, in case some of you aren't familiar, PICO it's it's an acronym for population, intervention, comparison, and outcome. This is a retrospective study, so this format may be a little bit different for this application, but I did try to integrate it. And so the population that's being studied, it's it was we used or not we so the study used ESO, so that it's a large EMS electronic health record consisting of EMS agencies who permit research using their de-identified records. This study was performed in 2019, so specifically January 1st, 2019 to December 31st, 2019. And in this ESO, that consisted of 8 million encounters, so over 8 million, so 8,430,148. Specifically, when they queried for encounters that involved the use of ketamine, and that involved 15,000 approximately administrations. That was specifically for 11,000 patients. So some of these patients received several doses of ketamine. And it involved a total of 458 EMS agencies. So I'm sure this involved, given that volume of EMS agencies, a combination of rural and urban. Those were the inclusion criteria, which is very broad. And then the exclusion criteria, it did not, or it took away patients who were involved in interfacility transport, cardiac arrest prior to EMS arrival, and those that were receiving an infusion of ketamine. Um, so again, this is a retrospective trial, so there wasn't necessarily an intervention, but there were specific um, uh, data points that this research was intended to collect in order to um, come to a conclusion in regards to its primary outcome. So some of those data points included what was the out of hospital dispatch information, what were the patient's demographics, what was the clinical presentation and course, what were the interventions in addition to administration of ketamine, like, what was pulse oxid, assessed was end-tidal CO2 assessed, etc. And what were the final outcomes? They also assessed the indications for ketamine use. Why was ketamine administered in those specific cases? And they were categorized. They were separated into 5 different categories. Um, Administration indications included reasons such as trauma or pain, altered mental status or behavioral emergencies, cardiovascular and pulmonary reasons, seizure, and other. They didn't specify what the other included, but there was an other category. The cumulative dose of ketamine, the reason they mentioned cumulative is because sometimes patients were administered several doses of ketamine. So there was a total dose, which can seem like a lot if you just account for the milligrams, but they also separated out into milligram per kilogram doses. Um, they specified the route of administrations. Uh, they identified if patients became hypoxic or hypercapnic before or after the event, and the patient disposition, both pre-hospitally and in the hospital. So pre-hospitally meaning, was the patient successfully transported to the hospital? Did they die, or was there an AMA? And then in regards to the final hospital disposition, same thing. Were they admitted? Were they discharged or AMA'd, or did they die? Comparison, again, this was a retrospective study, and they weren't necessarily comparing something, ketamine to another agent. They were just simply investigating ketamine as a drug, its safety profile, and whether it resulted in mortality. But I thought this part may be appropriate to place in the comparison section. Basically, as I'll get to later, there were a total of, so of those 9 million or over 8 million encounters that they uh, started with, it boiled down all the way to approximately 11,000 patients that had fulfilled their inclusion criteria. Um, of those 11,000 patients, about 1,877 patients, they were able to follow through all the way into the hospital. And so ultimately, they found, and I'll get more specific into this, but ultimately they found 129 patients who had died. Um, Basically, 8 of them were pre-hospitally, and 121 of them were in the hospital. And so essentially, of those 129 patients total that had died, there were 4 physicians, all of whom were board certified in EM and EMS, and they reviewed those cases. The reason they reviewed it was to see if the reasons for those deaths can be attributed to ketamine, or more specifically, um, they wanted to see if ketamine could be confidently excluded as a contributing factor to their death. And if they could be excluded, then great, they move on. But if they could not be excluded, if ketamine could not be excluded as a reason for their death, then those cases would be labeled as unable to exclude ketamine as a contributing factor to patient death. That does not infer causality. That does not mean that because they could not exclude ketamine as a reason for death, it does not mean that ketamine was a reason for their death. But it was. I just wanted to make that point clear. There was just not enough information to exclude it. And so again, the O is outcome. So the primary outcome that they were looking for was essentially how many of these cases in which ketamine was administered resulted in death. And what it showed ultimately was ketamine may have contributed to 2 out of the 8 on-scene deaths, so out of hospital deaths, and 6 of the 120 in-hospital deaths. And so and I'll get more specific into this, but essentially if you break it down, that is basically less than 1% of those who had received ketamine, we could possibly attribute their death to the administration of ketamine. Ultimately, the risks versus benefits have to be weighed when administering ketamine, and further research on the safety profile of ketamine in comparison to other alternative agents still need to be performed. So there's a lot of numbers here, and I don't want to confuse anyone, but I'm going to try my best to explain what this study had shown. So again, they queried this large EMS electronic health record system that consisted of over 8 million EMS encounters. 12,000 of those encounters involved the administration of ketamine. Using their inclusion and exclusion criteria, they came down to 11,291 patients in which ketamine was administered out of hospital. Now, 8 of those had died. So 8 out of 11,291 patients had died pre-hospitally. And so, again, just going to this right side, that would mean that about less than 1%, 0.7%, had died pre-hospitally. 8 of these patients, all 8, they were investigated by those 4 physicians to see if there is a possibility that ketamine may have been a contributing factor. It was determined that 2 of those patients, 2 of those 8 patients, there's a possibility ketamine could have been a contributing factor. And so that, again, 2 out of these 11,000 patients, 0.01% possibly could be due to the ketamine. Now, as you guys all know, and our system now is a little bit better, but this doesn't apply to all systems, but the charts that they were able to query, they were not able to follow through with all those patients in the hospital. Only 18% of this 11,000 patients, they were able to follow through into the hospital. So again, these numbers are getting really confusing, but because the 2,000 is not accurate, but there's 1,877 patients. Basically, just to break it down, 2,030 patients, they were able to link up. They were able to find records in the hospital. But 152 patients, they were missing the mortality data. So 2,030 minus 152, that's 1,877 patients. 1,877 patients, they were able to follow through into the hospital and identify whether they died or not. So of those 1,877 patients, 121 died. So again, that means that that's about a 6.4% mortality rate. So patients that they were able to follow through into the hospital who had been administered ketamine pre-hospitally, 121 of them died. Of those 121, again, the physicians had, those 4 physicians had investigated those charts and tried to see if ketamine could have possibly attributed to their death. Of those 121 patients, 6 of them, they could not confidently exclude the role of ketamine as contributing to their death. So there is a possibility ketamine could have resulted in their death. So that is approximately 0.3% of that population so the mortality rate probably is possibly 0.3%, again, less than 1%. So the overall mortality, so basically 2 of these patients that had died pre-hospitally and 6 of these patients that had died in the hospital, total of 8. That's 0.4% of the total 1,877 patients. Ketamine could have played a role in their death, so less than 1%. There were several limitations to this study. The number one, in my opinion, being simply that those 121 charts that had to be reviewed, and they were reviewed by adequately trained physicians, nonetheless, that still leads to some possible confounding factors and biases. Ultimately, they all had to agree if ketamine played a role in a patient's death, but these are only for physicians, and there could be opinions, and there could be practice patterns. It's ultimately, this is not, their opinion is not factual. They are still opinions. So this is a limitation of the study. There is a possibility that although it was found that 8 cases were attributed, possibly ketamine played a role in their death, maybe there was more, maybe there was less. In regards to just a very small discussion, because Brian will be talking more thoroughly in regards to his case that is in some relation related to this. Patient death falling out of hospital ketamine was rare, generally speaking. Most deaths were due to an underlying medical or traumatic cause. In a very small number of cases, ketamine could not be ruled out. And there was, and again, just to reemphasize, the inability to exclude ketamine does not imply causation. Just to go a little bit more in depth into the results, because although I discussed the primary outcome that this study was intended to investigate, clearly going back to this, like there were 11,291 patients, and they had basically acquired data that is useful in just understanding how does ketamine work and what is its safety profile. So to give an example, we can go all the way down here. Hypoxia was observed in less than 10% of these patients, and transient respiratory depression did occur. It occurred mostly at a total dose of more than 10 mg per kg, which is we rarely ever give. But just realize if you're giving incremental doses, several doses, you ultimately could possibly give more than 10 mg per kg, and it could result in transient respiratory depression because hypercapnia was relatively common. It was observed in almost 1 of every 6 patients. And other data that they collected was, what was the most common reason why ketamine was administered in the field? It was most commonly administered in traumatic injuries and to control pain. The median dose for the medication for ketamine that was administered for pain reasons was 0.5 mg per kg, which does fall in line with what we tend to give, which we tend to give between maybe 0.1 to 0.9 mg per kg, somewhere along that line. Another reason why ketamine is commonly administered, again, is for altered mental status, agitated delirium, etc., agitation, and the common median dose for administration of ketamine was 3.7 mg per kg. Again, we tend to give between 3 to 5 mg per kg, so it was reasonable, the median dose that was generally administered. So I didn't want to go too much in depth into all the results that they found, but these were the most common, or the most, in my opinion, relevant results that we can see. In conclusion, ketamine is often used in the out-of-hospital setting. Indications, as I had discussed, were altered mental status, behavioral reasons, trauma, pain, cardiovascular, pulmonary reasons, seizures. The study showed that out of 1,877 patients, there was a small percentage, less than 1%, in which ketamine could have contributed a role in their death. And ultimately, though, further research is needed to evaluate the safety profile of ketamine, especially in relation to its alternatives. For quality checklists, was the clinical question sensible and answerable? The clinical question was, is ketamine safe and does it result in mortality? It is a broad question, but it is sensible and I think it is answerable. We just obviously need more data. Was the search for studies detailed and exhaustive? There was over 8 million EMS charts that they started with, and it came all the way down to 1,877 that they truly could go through. So it wasn't exhaustive, but there was a lot that they started with, and I think it was good. Was the outcome clinically relevant? Yes, the outcome was, their primary outcome ultimately stated that there a small percentage of patients who received ketamine did die, and there are side effects that are relevant to ketamine that we do need to consider, but risk versus benefits is something that we will always continue to have to think about. It is not a completely benign drug, but its safety profile does seem to be favorable. The study does address a clearly focused issue, in my opinion. It does focus on whether ketamine is safe or not. The authors, did they use an appropriate method to answer this question? I mean, they used a very large EMS electronic health record to query this question, and I think it was an appropriate method. The cohort that they recruited, was it done in an acceptable way? Again, they queried a large EMS database. I think it was acceptable. have authors identified all important confounding factors and biases? The answer is no, as I had discussed earlier. Um, you know, when they did find out that 129 patients had died, ultimately they relied on the opinions of 8 or 4 board certified physicians, which is great, but like it could still contribute to some biases, opinions, and confounding factors. How precise are the results? I didn't go into it, but there was data that was missing. For example, 32% of the patients, there was missing data on whether the patients had end-tidal CO2 or not. Obviously, not every EMS agency has this capability, so I understand, but there was some data that was missing and could have affected the results. Do I believe the results? Generally speaking, yes, I do believe the results. Can the results be applied to local population? They queried over, I think I mentioned over 300 EMS agencies. So yes, I mean, ranging from urban to rural, I'm sure those agents, there was a wide variety of EMS agencies it encountered. And do the results of the study fit with other available evidence? The current available evidence is, generally speaking, ketamine tends to be a safe drug depending on what you're using it for. And so I do feel that it is consistent with the current available evidence. And that's it. That's all I got. Any questions or comments?
I'm going to wait to do some of the discussion till after Brian's section that he's going to discuss about, because it touches on a lot of the same subjects. Specifically looking at this article, the one thing that I would say is that so I'm sure some of you are aware of the background, why this was even published. I know a lot of the actual authors on there, and this was essentially in response to what was going on in Colorado. And that's what Ryan's talking about. Specifically, they were also looking at basically stating that, hey, is ketamine safe? Is the use of ketamine safe? So they made it very, very hard to exclude cases and that's why they said, in 0.4% of those patients, they were not able to exclude ketamine as a cause. But for the most part, we already know that, ketamine will kind of take away that adrenergic surge. It kind of helps to sedate the patient a little bit. And then possibly, the underlying medical condition is really what's coming through at that point. So let's if no one has anything else to say about the article, let's go straight into this case review.
Can everyone hear me?
Yeah.
Yeah.
All right. Thanks, Shaw, for that review. And yeah, the point of this was sort of just to go over the review article on the safety of ketamine out of the hospital, and I'll be going over sort of the Colorado case involving Elijah McClain, and mainly going through it through the lens of EMS and the safety of ketamine, as well as the response that they found in the investigational panel, as well as the investigation by the Attorney General. I won't be really going into the sort of the paramedics being on trial or really into the role of the police in this case, but mainly concentrating on the medical side. Just to give a background, so the city of Aurora is provided EMS by the company called Falk Rocky Mountain, which is a Danish-owned private company that has contracted with Aurora Fire since 2015, responds to about 30,000 EMS calls a year. And usually, to most scenes, the Falk ambulance and Aurora Fire and Rescue respond together on calls. Within 4 years of training, all Aurora firefighters receive training to become EMT paramedics. Aurora Fire provides the medical control as well as ALS, and Falk provides the ambulance and medical supplies, and Aurora provides the medical director. In 2018, Aurora Fire requested and received a waiver from Colorado Department of Public Health to permit paramedics to administer ketamine at a hospital. It required ketamine-specific training, protocol to be written, and reporting to the state after every use. It was suspended in September 15th, 2020, after McLean's death, by the City Council, and the waiver expired in 2021, and has not since been re-upped at all. The City Council set up an investigation of the events of the patient's death and was released on February 22nd, 2021. This is just a look at their protocol for agitation by Aurora Fire in 2019 during the time of the events. So if you look at it, it's pretty standard, and the actual doses here are not given, but per their protocol, they're giving a dose of 5 milligrams per kilogram for excited delirium, with the possibility of calling med control for a half dose following, with a maximum dose of 500 given initially. It requires immediate cardiac and tidal monitoring. It was high flow O2, and pretty standard sort of treatment post sedation, as well as cooling measures and transport to the hospital. This is the investigational report from the City of Aurora that was done after the death of Elijah McLean in August of 2019. The board included a double-boarded EM and EMS physician as part of the investigational panel. So in terms of the case, he was a 23-year-old male on August 24th, 2019 at 10:43 p.m. that 911 was called for suspicious behavior, where PD arrived and restrained the patient. He was placed in a left recovery position, and handcuffs were applied by the time EMS arrived. So EMS arrived at 10:53 p.m. They were told there was an agitated patient being restrained, told that the patient was vomited, was played in and there is sort of, per the investigational report, which did not have access to the paramedics. They were not interviewed, and the patient chart was not interviewed as well. But per the body cams by the police, which they looked at, there was some confusion in terms of who was given report. Some of it was given later. There are certain parts where it was told that the patient was vomited and was placed in a carotid hold to the basic EMT, but the paramedic was not given that information. And then the patient was sedated. So they were arrived at 10:53. Patient was given 500 milligrams of ketamine based on a 190-pound estimate weight at 10:59. Prior to that, the patient was not, there was no direct communication between the paramedics and the patient themselves. They basically mainly observed him from a distance. They did ask the PD to roll the patient onto the side for observation of his airway. There were some talks from PD about the patient's incredible strength and how strong he was. He was given 500 milligrams of IM ketamine at around 10:59. At 11:01, he was moved to a gurney with what appears to be vomitus on the mouth. 11:02, he was decided to move to the ambulance for suctioning. And 11:04, a call was made to dispatch about a cardiac arrest. Patient CPR was started, BVM. Patient was intubated, had an IO placed, and 11:17, patient arrived in the ED. A ROSC was achieved at 11:22. Patient was declared brain dead 3 days later, August 27, 2019. Autopsy results on October 18, 2019 concluded that the patient died of indeterminate causes. So now that we've gone over sort of a brief overview of the case, for one thing, the patient did wind up weighing 140 pounds, which the max dose of 500 was given based on an estimate of 190 pounds. The max dose per his actual weight should have been 320 milligrams. And so the dose he was actually given is considered about 8 milligrams per kilogram based on his actual weight. So the panel had a list of concerns that they kind of addressed. And so this will be kind of like a lessons learned and preventional piece based on that. One was that there was no clear of transfer control from PD to EMS. And their solution for this is not very clear. It was, sort of build a culture of patient advocacy and reviewing current policies, but it is clear that there is no direct control by EMS until the patient has been sedated by EMS. The other concern was that there was no clear sign out. There was information loss in terms of the main paramedic did not hear that the patient had periods of loss of consciousness due to the carotid hold placed by PD. And certain other aspects of the handoff were given piecemeal throughout the patient encounter. It goes to speak that there should be a interdepartmental consistency in handoff between EMS and PD. Even something as simple as who, what, when, where, and what procedures or any sort of pain application or things were done applied to the patient. The other concern was that there was delayed and incomplete assessment of the patient. There's no verbal interaction between EMS and no physical contact until the patient was administered ketamine. So there was no finger stick cardiac monitor or temperature performed prior to administration of the drug and their decision to call it excited delirium. And there was also a failure to bring equipment to the patient's side prior to administration of the drug for the sedation. So they arrived at 10:53, and when the medicine was administered about 7 minutes later, at that point there was still no equipment at the patient's side, with EMS not actively participating in examination or any other sort of exam of the patient. So that should have been adequate time for them to bring at least suctioning, the life pack, and other things to the patient's side in order to quickly apply vital sign monitoring to the patient. And then lastly, the inaccurate weight. Now, we all know that it's very difficult to accurately measure someone's weight. According to their protocol, which is basically look at yourself and compare your current weight to the patient's weight and see if you can kind of guess approximately where they are based on that. But there could be possibly more reasonable tools to be used, such as maybe an adult Broslow tape, or even using, there have been camera devices apps and stuff that can be used to guesstimate a patient's weight just based on their height. And so they asked for more training regarding the patient's accurate weight estimations, which, they don't really give a good solution to that. They just suggested that. So what resulted in this was updates to the Aurora Fire sedation protocol. And so they had some suggestions from their side. The panel had some suggestions to be given to Aurora Fire. One was improved protocol linking, that different aspects of their agitated patient versus excited delirium versus airway should all be linked on their PDF and their manual. That's more of a issue with the actual manual itself. Then they suggested a physical checklist for sedation. I know some EDs do this, and it's not completely out of reason to have like a small checklist to be performed prior to intubations to make sure, everything is there at the patient's bedside before doing this procedure. They recommend early and tidal use. Again, this is, I think the major problems with the optics of this case was that it was not there near the patient at the time, and he was being held down by PD. And so it's arguable whether or not they could have applied end tidal really that much sooner, but having it at the patient's side would have seemed like they attempted more rapid assessment of the patient, finger stick prior to sedation. And they also recommend a sort of temperature, not contactless temperature of the patient. And we'll go down later to talk about this, but basically the panel's information on this is driven mainly by ACEP's white paper clinical guideline of excited delirium in 2009, in which nearly 95% of patients with excited delirium had a fever as one of their presenting symptoms. And so using this as proof of the patient's diagnosis of excited delirium, or could be used to sort of guide this diagnostic pathway, and so if the patient was not febrile, that they would go down a different thought process and diagnostic pathway. The accuracy of some of these contactless thermometers, though, has been called a question, but it's an interesting suggestion, but just another sort of tool that would have to be carried at the bedside. The other things they wanted to add was supplemental O2, which was already part of their original algorithm, IV fluids, and then they talked about administration of bicarbs, stating that based on the white paper, acidosis is one of the major hallmark signs of excited delirium, as well as rhabdomyolysis with hyper K. They suggest using sodium bicarb as treatment for these patients to treat the acidosis, hyper K, and for alkalinization of the urine, for ion trapping for the rhabdo, and recommend, especially in cardiac arrest patients. They also recommended a automated QA for all ketamine administrations, which was already being done. So this is just review of that. Other things they talked about were body cams for EMS, which is its own sort of bag of worms there. And then they also suggested remote monitors, which is an interesting suggestion, I think. And we can discuss all this afterwards. I think I hope this becomes more of a conversational lecture. But yes, the thought that you can't really get leads on this person because they're being held down by PD. Potentially, you can put some kind of single lead device that can get you at least the basic vitals, O2 sat, respiratory rate, things like that. In this current climate, we all sort of carry, a lot of us carry portable pulse oxes, and even that alone could be very helpful in monitoring the patient, especially if a single extremity is held pretty still by the PD. At least that can give you basic information, and arguably could have alerted the paramedics of any decompensation sooner, or whether or not the patient actually needs sedation at that point. And then the other thing they suggested was telemedicine online med control, which, again, in a patient with very severe agitation, this is arguable whether or not that's, can run around chasing the patient with a iPad so that the online med control could just see just how agitated the person is arguable at best. In regards to the ketamine, what they eventually said about the ketamine suspension, they believe that there's ketamine is not only, and I'll quote them on this, this memorandum prevents the use of ketamine not only for sedation in the setting of profound agitation, but for other indications for which ketamine has demonstrated emerging benefits, opiate pain-free control particularly. This memorandum also means that Aurora Fire paramedics must rely on medications demonstrated to be less effective in patients with significant agitation, such as medications discussed above, which potentially compromise both Aurora Fire personnel and patient safety. The panel understands that the FDA may issue guidance on pre-hospital ketamine use by the end of 2021, and the panel recommends that the city monitor and assess these guidance as it is assessed whether to permit EMS use of ketamine in the future. And I think they give a pretty balanced view on this, and ultimately their suggestion is potentially using a lower range of ketamine, and instead of the 5 milligrams per kilogram, using a 3 or 4 milligram per kilogram an initial dose for sedation. And this is based mainly on a joint statement by ACEP, NAEMSP, and the College of Surgeons Committee on Trauma, basically stating that 5 milligrams per kilograms was associated with increased intubation rates when they arrived at the hospital. Now, the statement was the data they reference is 2 studies, both 50 or less patients, both observational and retrospective in nature, and from 2015, one from Australia. And some more recent studies have shown that even on the patient ones where intubation in the hospital was high as a result of ketamine administration out in the field, it's possible that this is due to providers in the ED being uncomfortable with the low GCS presentation of some of these patients. For example, one paper showed that most of the intubation done for ketamine was a single provider, showing that it may be possible that if EM providers were more comfortable with ketamine administration as a whole and the presentation of that patient once they've been sedated in the field, that the percentage of intubation post sedation would be less. And here's a study, just basically looking at the use of ketamine out in the hospital versus another good option, midazolam. And this is an interim analysis of an open label prospective study of a single EMS system transporting patients for agitation. All paramedics were trained using the altered mental status scale, which was also used in in another big study where they compared Haldol versus Ativan versus Versed and all the other drugs in sedation of agitated patients in ED. So all paramedics were trained on that, and they gave actually a very interesting sort of tiered response, where 3 milligrams per kilograms were given for an AMSS rating of +2 or +3 versus 5 milligrams of midazolam, or a 5 milligrams per kilogram for profound agitation for AMSS of +4 versus a whopping 15 milligrams of midazolam. And what they found was with 295 patients enrolled at that point, 203 received ketamine, 92 received midazolam. The time to adequate sedation in all patients, including the less profound agitation and the profound agitation patients, was 4.3 minutes for ketamine and 6.7 patients for the midazolam. And what's more interesting is that for the profoundly agitated, so those most concerning for possible excited delirium, the time for adequate sedation for ketamine was 4.6 minutes and 10 minutes for midazolam, even though they were given doses of 15 milligrams of midazolam. And if you look at the safety outcomes, they're relatively similar in that, and even in the apnea between ketamine and midazolam. This is just another review study of ketamine use in the pre-hospital setting, and what they basically found was that there was no significant increase adverse events from use of ketamine in the field. This was done in the ED and showed that there was minimal, vital sign and intubation rates among patients with given ketamine in the emergency department for agitated sedation. Just a apart from that showing that. So this response to this was a House bill after the panel investigation was performed in June of 2021, basically dictating the use of ketamine in the pre-hospital setting in Colorado from henceforth. They stated that what justifiable medical emergency meant, and you can read it right here, but basically means a medical, traumatic, or psychiatric condition, possible risk to individual, EMS, or the public. And basically that it should not be used, ketamine should not be used absent a justifiable medical emergency, and especially not for sedation for criminal or suspected misconduct. And they also go on to say excited delirium is not considered a justifiable medical emergency. So the problem is excited delirium itself is a controversial diagnosis. It was first sort of mentioned in the literature as a Bell's mania in the 1800s, but wasn't really called excited delirium until the 80s due to the increased use of cocaine and methamphetamines among people. And so, even most recently, the study looked at, this was a 2019 Academic Emergency Medicine review of excited delirium in the literature, and really didn't find much, most of it being, case studies with no definitive pathophysiology and definitely no universally accepted definition, which makes it very, very controversial, as the American Psychiatric Association does not recognize excited delirium due to a lack of criteria. And there was also a statement by the AMA in 2021 stating much the same thing. So there are two major papers from ACEP, which does recognize excited delirium syndrome as a real syndrome. There's a 2009 paper, white paper, which a lot of what the panel and the Attorney General's investigation are based on, as well as the 2012 ACEP task work, which defined excited delirium as an excited delirium syndrome is characterized by delirium, agitation, acidosis, and hyperadrenergic autonomic dysfunction, typically in a setting of acute on chronic drug abuse or serious mental illness, or combination of both. The 2009 paper, it's really interesting because it actually does go into the controversy, even in 2009, about whether it is used as a cover-up sort of diagnosis by law enforcement to cover police brutality and the lack of recognition by other medical societies. It goes to give a possible pathophysiology of a dopamine theory, basically citing that there's, in these postmortem autopsies, there's a loss of dopamine transporters in the striatum and the hypothalamus, which may explain the temperature instability. It almost sounds like an NMS sort of condition based on what they're describing. But if you read this, this is their sort of description of an excited delirium state, and in some ways does coincide with the Elijah McClain case with the sudden death after after a struggle with law enforcement and a failed definitive cause of death by autopsy. And again, just more description of the excited delirium syndrome. They go on to state again that sweatiness, increased pain tolerance, agitation, tactile hypothermia, again, with a frequency of 95% in these patients, goes to, which is why they suggested things like temperature measurement before a diagnosis of excited delirium. Mortality in their cases being anywhere from 8 to 15%. Sorry. And this is so in 2020, the Senate Bill 217 basically authorized the Attorney General to conduct investigation on Aurora Police and Aurora Fire. And so unlike the prior investigational report by the panel, this is done on all of Aurora Fire's use of ketamine and not just that one case involving Elijah McClain. And so this is more broad strokes in terms of the patterns of misuse by the department that they're claiming, and also notably did not involve a medical doctor in the panel. And just so I know there was talks about one big thing. You'll notice in the suggestions by the private panel, there was not a suggestion that that EMS should not take direct orders from police, but in the media, there's been big talks of that, and I think it's been kind of confusing because they're talking about two different things. There was another case in which a patient was administered ketamine, where the police had seems like giving orders to paramedics, but specifically in the Elijah McClain case, there was not that. We'll just see a little clip right here.
Aurora paramedics have administered ketamine 25 times since 2018, most notably during the detainment of Elijah McClain.
The decision to sedate a patient is supposed to rest with medical professionals, but recently Denver 7 investigates uncovered video that shows officers giving the orders.
And the attorney representing McClain's family was watching, spoke to our Jennifer over.
It's this police body cam that Denver 7 investigates first reported on. I wasn't surprised one bit to see the report that you did, and what an Aurora officer says on it that caught the attention of Attorney Martin. You're listening to an APD officer asking paramedics.
So basically, the controversy on this statement is that the police officer asked the paramedic for station meds, and the paramedic responds in a positive manner, almost seeming like taking orders. Again, not seen in the case of Elijah McClain. The definition of excited delirium by the Aurora Fire manual said excited delirium is a rare medical emergency in which a person develops extreme agitation, aggressiveness, overheating, and exceptional strength that cannot be managed by routine physical or medical techniques. What the investigation found was that between January 2019 to September 2020, ketamine used 22 times for excited delirium, with some adverse reactions, including tachycardia, hypoxia, and bradycardia. All these patients that had adverse reactions were given the max dose of 500 or given the dose after another sedative was given. 3 patients were given too much ketamine for their weight, as much as 50 milligrams above. And I guess what's more concerning is that 5 patients did not receive capnography. 11 patients, this is out of the 22, 11 patients did not receive cardiac monitoring. 4 patients did not receive pulse ox, and 2 patients had no monitoring whatsoever, with only one of the notes stating that the patient behavior prevented monitoring, but the other one did not have a written excuse as to why the patient was not on monitor. 5 of the patients did not receive any documented weight and were all given 500 milligrams. And you can see here, unknown weight, and there was no documentation of monitoring afterwards in a couple of these cases. here as well. So what this does is show basically a pattern of improper sort of monitoring post giving these patients sedation, which, I think appropriate or not, given the patient's agitation at the time, I think this really goes down into how documentation is done and really speaks to how things can be twisted or inferred based on the lack of proper documentation. Basically, per the investigational report, they stated that the Aurora Fire Rescue has a pattern and practice of administering ketamine illegally, citing that they used doses that exceed maximum allowed by protocol. They failed to estimate patients' weights, weren't sedated, or after sedated, weren't properly monitored, and included cases where ketamine was administered at the request of an officer. The medical director is supposed to review all these cases, and not a single one was flagged, despite improper monitoring and improper weight of the patient. They go to say that the use of 5 milligrams is considered high, and again, referring back to that that joint position statement by the ASF, NAEMSB, as well as the American College of Surgeons, that 5 is associated with increased rates of intubation. And they go on to suggest that possibly using a validated agitation scale, such as the Richmond Agitation Sedation Scale or the RASS score, prior to sedation, would be useful in documenting why this patient needed sedation in the first place. Another option would be the altered mental status scale, which seems a little less more useful in the outpatient setting versus, for example, the RASS scale. Patient pulls or moves tubes or catheters. That's not really as useful in the outpatient setting. Again, and so these are their suggestions, and I think at this point, these are just the findings of what they, based on what they saw and the patterns that they saw, and based on the. Sorry.
Yes, some of this is just going to be, like a lesson in, optics being, public perception. When you show up on scene and the police are like, give him the ketamine, they're not directing patient care. It ultimately falls under the medical director. And this is also why we stress, following your protocols. For a while there, you were really making Dr. Wong very happy with, focusing on, the documentation. And there's these specific points of, documenting that you followed your protocols, that you did the appropriate medication, the appropriate dosage. If you didn't document like a BGL or a pulse ox, why? The patient was, screaming at you and trying to attack you. That's a good reason to not do some of those things. But once you gain control of the situation, you have to do good patient care. This is one of the reasons why this case has been in the national media. This is this has been going on for probably, the ketamine story has been going on for at least the last 3 or 5 years.
So Brian, thanks for the thanks for the presentation of the of all of this. I think you really did a nice job covering things that are going on here. Anybody have any initial comments?
Yeah, I got a few actually. Can you guys hear me?
Yeah, go.
Yeah, so I think once again, medicine, emergency medicine, EMS, we're at the mercy of the media and optics, right? And I think that's what this all comes down to. Even back when Dr. Conrad Murray, Michael Jackson's physician, inappropriately used propofol for him behind closed doors, no good monitoring, Michael Jackson died. And what happened? All of a sudden, propofol is the bad drug. Propofol gets pulled off the shelves. No hospital has propofols. So that kind of messes with the flow of the ED and how we did stuff when that medicine was used correctly. And now here comes ketamine, and ketamine is now the pit bull of the litter, so to speak. So I think the issue is that, one, just like any other drug, oxygen, saline, if you want, we can name hundreds of drugs that we have pre-hospital or even in the hospital that, if used a certain way, can be harmful to a patient. That's correct. No one will ever argue that. But I think what really needs to be highlighted here is that these medications are used inappropriately. It's used inappropriately. These patients are monitored with whatever reason they're used for. They're not monitored. So of course there's going to be some type of side effect. Of course there's going to be some poor outcome because it's not used properly, as could happen with any other drugs. But I think we allow, and I say we as medicine, allow this narrative to go on as if, oh, it's ketamine, it's ketamine, it's ketamine. Man, we've been pushing how many rounds of epi for days, and people come up with poor knowledge, but outcomes still. You get what I mean? So I think, and it goes back to what Nava said to optics, yes, but we've got to have a way to stand up and hold individuals accountable for not using these medications or not doing the right thing, and not let just saying, oh, it's ketamine, it's ketamine. Then you have all these laws, and who the hell, sorry for the language, is really going to have the time to do some, go through the scale and check all the check boxes when you have this 6'5" guy, 280 pounds, tossing people like, rag dolls. We have to be realistic, and medicine, we need a better backbone when it comes to stuff like this. This all comes back down to, I believe, user error, team error for not doing the right thing the right way all the time. And we can't just say, oh, it's just ketamine, and now put a whole other hurdle in front of that. Now you have to do another documentation. Now you have to review this one. They have to review this one. You have to review this one. It's just, it's never going to end. There's always one more task they're going to add on for us to do to try to fix something, when in this case, it's user error, I believe, 100%. Do the right thing.
Yeah, no, absolutely. And one of the things is you have to be able to show that you already have systems in place to ensure that, that these things are remediated, that these things are not commonplace. And, that's one of the things NAMSP actually kind of sent a delegation to Colorado to kind of like try their best to mitigate. It's called damage control, because once it's out in public opinion, now, how do you approach that? You need a good public speaker. You need someone to come in with a reasonable head to be like, hey, well, we understand that this is a bad outcome. This is the procedure in place to address it. And, you also want to show that there isn't a pattern. And I think that was the problem with this, is that they found a pattern of, people not being remediated, people, not getting things done correctly.
So guys, a couple of comments here. The first is that to Navin's point about the pattern, what they found a pattern of was poor QA, QI, and poor medical direction and poor follow-up. So, thankfully we work in a system that's stressed heavily. But this is a profound example that's seen all over the country of things happen all the time. They're missed, they're not caught, and they fall through the cracks. And sometimes when somebody goes back and looks at each individual case, that can be used to establish a pattern. The other piece of this is that EMS is its own little house in the house of medicine, and it's a pretty new house, and it's still being built. And so you're going to get a lot of people from outside commenting on it. You're going to get a lot of heavy criticism of it. And if you want to be part of the establishment, and EMS does, it's its own boarded specialty, you have to take care of your house. And how you take care of your house is by doing a good job. You make sure you have solidly written protocols, you make sure you have good QA, QI, and you make sure that you actually are delivering quality care. And as soon as you start not doing those things and you screw up drug dosing, or you have the wrong indications, or you don't have the proper monitoring, you leave yourself in a liability like this situation. So what this boils down to is all the fundamentals that we try to teach over and over and over again about delivering quality care. There are a couple of specifics to ketamine as well that I want to make sure that are addressed and talked about. One is there is a difference between the IM and the IV dose, and that needs to be respected and understood. And then the other thing with ketamine specifically is the danger zone for ketamine is in the subdissociative range. All right, and depending upon which study you look at, I was just reviewing the WHO document on this while you guys were presenting. It's anywhere from 0.1 mg per kg to 1 in the IV form. All right. So in the middle range is where your big danger is in ketamine. And if you'll notice, the 0.1 can sometimes start getting a little bit close to the pain dose. And sometimes you see that. You're using very low dose ketamine for pain, and you end up putting people into this semi-euphoric or semi-agitated state, depending upon how they react to the medication. So quite often, the answer to that has been use higher, use more of it. And that's fine. And actually, as long as you're taking the airway, using higher doses is fine. What we're trying to do in this specific situation of sedating the agitated patient is give enough to sedate the patient without taking the airway. That's considered a failure of, or now you're on a side algorithm. So pay attention to these things, understand where your dangers are, follow your protocols, and actually treat this like a patient, all right, in every way. You need monitoring, dosing, and I guess the last point I would make is that you're living in an age where everything can be put under the microscope to a degree that I think people are not necessarily aware of, with body cams, with the ability to pull up all the old data, to the ability to pull up every single end title tracing from every monitor, so when you put yourself under the microscope like this, it can get pretty uncomfortable. The best thing to do is to deliver quality care up front so that you don't get put under the microscope to that degree.
Yeah, guys, I think we're just we're running over, so we're just gonna close it up. Next journal club is gonna be December 8th. And that's it. For the fellows, stay on this line. I'm gonna take care of some things.